Good morning. I would like to present my lecture today, which is about pain. Pain is the most common symptoms that brings patient to a physician's attention. Pain can be defined as a complex, subjective, unlikable sensory and emotional experience, reflecting real or potential tissue damage and the affecting response to it. Classification of pain. According to the functional neuroanatomy, pain could be classified into nociceptive and neurogenic or neuropathic. Or we can classify the pain into adaptive and maladaptive. The pain of the nociceptive origin is divided into somatic and visceral type. The nociceptive pain arises from local lesion affecting the somatosensory system. And stimulates nociceptors. So the pain mediated by an intact nervous system. So please listen again. The nociceptive pain should require nociceptor with an intact nervous system, while the pain of neurogenic origin arising from abnormal neural activity, so it is defined as a pain initiated or caused by a primary lesion or dysfunction in the nervous system, which is central, peripheral, or autonomic. It does not require specific baroreceptors stimulation, although it can be made worse by such stimulation. Condition affecting the primary sensory neuron, which means the dorsal root ganglion and the dorsal root, are much more common than other parts of the nervous system. Also, neuropathic pain was typically divided into two types, which is namely picretic pain and protopathic. Picretic pain can be described as sharp, lancinating, and pricking, while protopathic pain described usually as dull, burning, and poorly localized. According to the temporal profile, pain can be classified into transient pain, evolved to protect man from physical damage by the environment or by overstress of the body tissues. Which is listed by the activation of nociceptor transducers in the skin or other tissues of the body, the absence of any tissue damage. The acute pain, which is the second, it is an essential biologic signal of the potential for the extent of injury. Is the pain that lasts for or is anticipated to last a short time, typically less than 1 month. It is often associated with anxiety and with hyperactivity of the sympathetic nervous system. You know what we mean by the hyperactivity of the sympathetic nervous system. We mean anxiety, dry mouth, palpitation, sweating. Acute pain is normal response to the tissue damage by activation of the nociceptive transducers at the site of the local tissue damage, and typically resolves as the injured tissue heals or soon after. Third type is the chronic pain, usually defined broadly as pain persisting more than 1 month beyond the resolution of any acute tissue injury. The pain recurring for more than 3 months, or pain associated with tissue injury that is expected to continue or progress, like cancer pain. So the chronic pain has no adaptive biological role. Although chronic pain may be due to persistent stimulation of nociceptors in the areas of ongoing tissue damage. Frequently, however, chronic pain persists long after the tissue damage that initially triggered its onset has resolved. And in some people, chronic pain presents without any identified ongoing tissue damage or antecedent injury. Such maladaptive pain typically results from damage to the nervous system. So, whatever the cause, the effect of chronic pain on the patient tends to be more invasive than that of acute pain, and it often profoundly affects the patient's mood, personality, and social relationships. The pathophysiology of pain. There are four physiological processes are associated with pain, which are nociception, transduction, modulation, and perception. The nociception is the detection of the tissue damage by specialized transducers attached to A delta and C fibers types. So the noxious stimulus is converted to an electrical impulse in the specialized sensory nerve ending by a process called transduction. A delta provided sensory input for immediate. The delta fibers provide sensory input for immediate sharp pain, whereas C fibers responsible for delayed dull pain. Nociceptive fibers terminate in the dorsal horn of the spinal cord. The initials modulation of pain, which alters the pain transmission. So, as you see, the pain impulse is mediated by delta, A delta, and C fibers, and enter the dorsal root ganglion, then dorsal horn of the spinal cord. In the dorsal horn of the spinal cord, pain messages meet up with specialized nerve cells that act as gatekeepers, which filter the pain messages on their way to the brain. That is to say, they have the initials modulation of pain, which means alters the pain transmit on. The large diameter myelinated fibers input control the gatekeeping in the dorsal horn by blocking the input from A delta and C fibers. Well, now we explain the processes of nociception, transduction, modulation. Now, what about perception? As the dorsal horn of the spinal cord projects the ascending fibers, which the fibers cross the cord, they are added to the inner side of the spinal thalamic tract. Then it arrives at the thalamus, a sorting and switching station located deep inside the brain, which is the thalamus. The thalamic nuclei project to the primary sensory cortex, which is post-central gyrus. So, perception lies at the level of thalamus, with the cortex being essential for the discrimination of specific sensory experiences, that is to say, its location, intensity, and quality. By pain processing, the perception of pain is further influenced by the rich interconnections of the thalamus with the limbic system that mediates emotional and motivation-related aspects of the nociception. The reticular activating system, or reticular formation, regulates arousal reactions and autonomic reflexes to pain. The hypothalamus mediates autonomic and neuroendocrine responses to the pain. There are certain definitions we have to exhibit to you to know. The pain system needs to be sensitive enough to detect potentially harmful stimuli. So, sensitization means an increase in the excitability of the neurons, so they are more sensitive to stimuli or sensory inputs. Pain hypersensitivity after an injury helps healing by ensuring that contact with the injured tissue is minimized until repair is complete. That's to say, an adaptive response. So, that normal inputs begin to produce abnormal responses. Sensitization contributes to tenderness and soreness. Sensitization can be divided into two types, peripheral and central. The peripheral and central sensitizations are the major causes of pain hypersensitivity after injury. What about the mechanism of revert pain? The convergence of deep and cutaneous afferents on the same dorsal horn cells, coupled with the fact that cutaneous afferents are far more numerous than visceral afferents and have direct connections with the thalamus, explains the phenomenon of revert pain. The individual experience of pain and the tolerance of pain depend on and can be affected by the emotional and psychological state, expectations, beliefs and values, age, gender, social and cultural influences. Evaluation of pain. A standardized approach is essential. First of all, history. So, analysis of pain as a symptom, onset and duration. Site, somatic pain often well localized, like sprain in the ankle, while the visceral pain more diffuse, like in angina. The pain of ischemic chest pain, it is usually diffuse and poorly localized. Radiation through local extension or referred by a shared neuronal pathway to a distant unaffected site. Character or nature, described by adjectives like sharp, dull, burning, tingling, and etc. Severity, mild, moderate, or severe. Course, what about the course? Course, if it is episodic or continuous. If continuous, any changes in the severity, and if episodic, periodicity and the frequency of the attacks. Special time to occur, variation by day or night, during the week or month. For example, relating to menstrual cycle. Aggravating factors, circumstances in which the pain is provoked or exacerbated, like specific activities or postures, and any avoidance measures that have been taken to prevent its onset. Relieving factors, effects of specific activities or postures include effects of medication, painkillers. And last, associated phenomena. Physical examination. It is essential, often helping to identify underlying causes and to further evaluate the degree of functional impairment. The location of tenderness provides important diagnostic clues. Treatment plans may differ depending on the type of the pain. The acute pain. The acetaminophen and non-steroidal anti-inflammatory agents. These compounds inhibit cyclooxygenase and prevent the production of the prostaglandins. These prostaglandins generate pain by stimulating peripheral sensory neurons during inflammation. Opioid analgesics. The opiates interfere with the pain transmission, act on the neurons of the dorsal horn of the spinal cord, suppressing afferent pain impulses from both A delta and C fibers. Also, opiates activate pain inhibitory neurons in the brainstem of the endogenous pain suppressing pathway. Capsaicin، هذا اللي نصطلح عليه احنا نبات الفليفلة. It is a cream that absorbed by sensor endings on the skin. It has a selective stimulation of C fibers and release of a substance which is called substance P, which is the principal transmitter of the pain impulses from the periphery to CNS, central nervous system. Substance P influences the excitability of the spinothalamic neuron. This release followed by a refractory period which reduces sensitivity, with reduced sensitivity, and after repeated applications, there will be persistent desensitization due to depletion of the neurons of substance P and prevents reaccumulation. What about chronic pain treatment? In most patients with chronic pain, the pain cannot be eradicated or cured. Thus, the goal of the therapy is to control pain and to rehabilitate the patient so that they can function as well as possible. First, systemic drugs. Here we will talk about 3 categories of drugs, which are antidepressant, anti-epileptic, and anti-arrhythmic. First, antidepressant medication. The analgesic effect of antidepressants has a more rapid onset of action and occurs at a lower dose than is typically required for the treatment of depression. And the patients with chronic pain who are not depressed obtain pain relief with antidepressants. The antidepressants enhance descending modulation. There are many painful conditions that respond to TCA, tricyclic antidepressants. These conditions: post-herpetic neuralgia after varicella zoster infection, diabetic neuropathy, migraine and tension headaches, rheumatoid arthritis pain, chronic low back pain, pain due to cancer, and central post-stroke pain. The anti-epileptics may be effective for aberrant shooting pain sensations. These result from neuronal excitability, producing abnormal discharge arising from peripheral nerve injury. Antiarrhythmics. These drugs block the spontaneous activity of primary afferent nociceptors that appears when they are damaged. Other maneuvers that are generally reserved for patients who have not responded to conventional pharmacological approaches, like counterstimulation. These physical measures, like heat, cold, vibration. Another type of counterstimulation is the transcutaneous electrical nerve stimulation, which is abbreviated as TENS. It is particularly for neurogenic pain and is the application of electrical stimulation to the skin for pain control. It appears to produce both segmental and descending inhibition. The methods of counterstimulation are less likely to be effective if there is significant deafferentation, which means the amount of sensory loss with neuropathic pain. 3 is the psychological methods include relaxation techniques, cognitive behavior therapy, which is abbreviated as CBT, These methods attempts to change pattern of negative thoughts and dysfunctional attitudes to foster more healthy and adaptive thoughts, emotion, and actions in the patient. 4, which are invasive procedures like local anesthetic nerve blocks, sympathetic blockade or sympathectomy for sympathetically dependent pain, neurolysis with chemical, thermal, or neurosurgical procedures. The indications are now few. Thank you very much for listening.